Welcome to Health Reform 2.0, the only place on the internet for people with a curious mind and a desire for a better healthcare system. Here we take you on a journey of our current quagmire, tell you where it came from and why the government can't fix it. Along the way, we'll tell you some history, bust a few big myths, tell you a few stories, and give you an idea how we can work together and get the healthcare system we want. Let's get started. Welcome back, ladies and gentlemen, to Health Reform 2.0. This is episode 1.12. 1.12. It is the last of our history series. And we're going to be talking about the years 2010 up to today, present time, 2018. We've spent a lot of time kind of going through all the things that currently affect our healthcare system all the way back to the 1600s. And as we move forward, you're going to find that most of the things we've talked about, we're going to tie into how they're affecting things we do today and why the existing system doesn't work and why the government can't fix it. As typically, I am joined by Tim Henning, and today he's in person right here with me again. And as we move off on telling you where we are now and laying the groundwork for our roadmap to sanity, you were up at your ranch. Did you fall out of any more trees, or?
No, I sore after that last event. Lucky enough not to get hurt. That's the last time I'm going up a tree or getting on a ladder. So we had a good time with the grandkids. We did cut down quite a bit of trees and brush from the ground level and got rid of that, as much as we could. And I also had some major technical issues with the computer system, as you know, that we couldn't record this then. That's why we're here today. So it was pretty frustrating on Thursday, let me tell you. But when everything goes wrong technically, it just goes wrong all at once, it seems.
That it does.
But just coming back, last night we watched the Warriors game, and it was fantastic, up 2-0. Going into Cleveland, they're going to have to play really good this next one. So I didn't bring my Warriors shirt. I was going to wear it today, but instead I brought my Las Vegas Golden Knight shirt. I was in Las Vegas 2 weeks ago, and
dating Celine Dion now.
I'm telling you, she came.
Does your wife know about this?
Well, she came out in that flurry jersey, and I don't know if there's anything on underneath of it or not. But her 50 years old, that girl looks good. Yeah. Great performance. But it's all the rage in Las Vegas, and we're supporters. First year as being a team, and they're in the Stanley Cup. Now we're down, 2 games. So tonight's going to be really interesting. So I've got my Golden Knights shirt on, and we're going to root them on here at 5 o'clock this evening.
Go Vegas.
Got it. Well, as you mentioned, we got to the end of your book, the History and Evolution of Healthcare in America. That was our starting point on this journey, because as we mentioned before, we wanted to get a grounding in the history, how we got here. We're both history buffs. Obviously, you wrote the book. But for me to understand where we are, I always have to understand how we got here. Mm-hmm. And so this is the last 2 chapters in your book, chapters 8 and 9. I originally said it was going to take 10 episodes. It took us 12. And the reason for that is the 60s and 70s had so much meat in them. Government regulation, intervention. And this has shaped a lot of where we are today in this unreal quagmire we refer to as a healthcare system, which we know is not a system at all. And we haven't even got yet to the Patient Protection and Affordable Care Act, commonly known as PPACA, ACA, or what we refer to as Obamacare. So, Tom, what are your thoughts so far on this historical journey we have been on in all these past episodes?
Well, Tim, when I started writing the book, I opened the book with the scene of Obama coming in to sign this legislation. And it was a historic moment in terms of, for a lot of people, for a lot of different reasons. Like many that were involved in this legislation in some form or another, I wasn't happy with the result. Now, I wasn't writing the bill. I wasn't sitting in rooms and discussing how to do it. I was reading the legislation in its various forms and providing feedback to people in Congress that were friends and I'd become acquainted with over the years, and basically sending back what worked and what I didn't think would work on the bill. And unlike what a lot of people claim, I have read every page of the various pieces of legislation that came out of all the committees, and I've also read every version of the full bill as it was moving forward to approval. And having read every version of the full bill, it gave me a very unique perspective into the pure duplicity of this legislation. Yeah. The reality of the bill is that its intention is nothing like what we, the public, thought it was or were being told. The plan wasn't to fix health care. It wasn't built to do that. It actually was to mess up the existing system with a series of small, potential, perceivably beneficial changes that was really a setup so that at the end, the public was going to bear witness, watch, if you will, as all these supposed efforts of the government, these fixes, failed, and they left the American healthcare system totally destitute. And they wanted to leave it in such a state where the people would be very favorable to replacing the failed mess with a federal single-payer system. And we didn't get the single-payer system in the legislation. I didn't want it. I don't think single-payer actually works. In fact, I will tell you, I think single-payer is a pragmatic misnomer.
Totally.
It doesn't really exist. There are no true single-payer systems in the world. But if we don't learn from this history, we ain't going to fix this mess, and we're likely going to bankrupt our nation very soon.
Yeah, they really pulled the wool over our eyes on this one. What they really wanted was Medicare for all or some other pipe dream of a plan, but they couldn't even get enough Democratic votes to pass a single-payer option.
Right.
And so it's, again, single-payer is a misnomer. It doesn't exist, and I don't think it ever exists, as you well explained.
Well, all someone needs to do is to look at the prior versions of the bill. Just go back online and look up the two prior versions of the bill and read them. And that happened about 3 weeks or 4 weeks before the final bill took place. And just look at the changes. If you want to read the whole bill, it's not all that hard to read. It's about 2 hours to read it. But if you don't want to read the whole bill, just go look at the one thing that became the big issue, the doctor fix.
Yep.
You can keep your doctor if you want to, and you can keep your plan if you want to. Well, if you look a few versions of the bill before, you will see there was no way on God's green earth you were going to have a plan to keep. And if you did have a plan, you were going to want it. The legislation clearly said in the earlier versions that if you kept your plan and you had a baby, you couldn't add the baby to the plan. For you to get your baby covered under insurance or a child or an adopted child or anything else, if you wanted to make a change to your plan, you had to get a new plan and cancel your old one. The second thing is the existing plans were going to go away because when you read that legislation, it was clear the insurance companies were never going to get any changes to those plans made. So as time went on, they couldn't change premiums. They could do nothing. They were going to cancel them. In fact, insurance companies did cancel a number of plans when the bill passed. But you won't know that if you look at the end result because they took out a lot of that language and weasel worded it so when you read it, it wasn't clear what the intention of the language was because they knew that if any of the American population read that, they wouldn't be so damn stupid as to want it approved.
Well, just as Nancy Pelosi said, we've got to pass this so we can understand it. And by God, we finally did, and we now understand it. So, Tom, Barney Frank, Charlie Rangel, Nancy Pelosi, and others actually said on television that the ACA was a path to a single-payer system.
If we get a good public option, it could lead to single-payer, and that's the best way to reach single-payer. Saying you'll do nothing until you get single-payer is a sure way never to get it. But
almost no one heard it or understood what it meant. Now let's go back, that came out later, a Professor Jonathan Gruber, who has been caught many times, recorded video and audio of him explaining that the American people were too stupid to understand any of this.
Okay, transparent financing, and let's have transparent financing, also transparent spending. I mean, this bill was written in a tortured way to make sure CBO did not score the mandate as taxes. If CBO scored the mandate as taxes, the bill dies. In terms of risk-rated subsidies, if you had a law which said healthy people are going to pay in, it made explicit that healthy people pay in and sick people get money, it would not have passed. Lack of transparency is a huge political advantage. And basically, call it the stupidity of the American voter or whatever. But basically, that was really, really critical to getting the thing to pass. What if we instead just levied a 40% tax on the insurance companies that sell these terrible, expensive Cadillac plans? We said, well, that's pretty much the same thing. And why does it matter? I said, you'll see. And they proposed it, and that passed. Because the American voter is too stupid to understand the difference. So basically, it's the same thing. We just tax the insurance companies. They pass it on higher prices. That offsets the tax break we get. It ends up being the same thing. It's a very clever, basic exploitation of the lack of economic understanding of the American voter.
And they purposely knew it was a fake and a fraud, and they put it out that way, knowing all the well good it was going to fail and get to the end game where they wanted to get to, and that was a single payer system.
Exactly. And the bill was duplicitous from the very beginning. And of course, we're the ones that are left with this travesty.
Yep.
They said, the CBO, meaning they, that it was going to cost us $800 billion over 10 years when this bill passed. That was their estimate of what Obamacare, the Affordable Care Act, was going to cost us as Americans over 10 years. Well, I predicted before the bill even finally passed, I ran my own numbers, and I thought it was going to cost us well into $3 trillion. And in fact, recently, the CBO has come out, and their estimate is more than $3 trillion now for the existing act. And that is with changes in the law that never took place. Parts of the law have never implemented. There was a fairly large bill for a thing called SAFE, which was a home care program that never implemented because it wasn't affordable, and a number of other things that have now gone the way of the white whale, and they're now claiming it's still going to cost more. Mm-hmm. So that's the first part of it. And the CBO also said it was going to lower our premium costs. They were going to bend the cost curve down. It was going to save us about $2,500 a year was what they said. And I said at the time that in 2009, when the bill passed, the average out-of-pocket cost per person under health care in the U.S. was $8,500, and that was in 2009. I said it was going to cost us $17,000 by 2017, and in fact, it cost us more than $17,000 by 2017. And today, if you look at the estimates, it's going to cost us about $25,000 per year per family by 2020. That we're going to be out of pocket if we need health care. So it's just astounding when you look at what they used to sell the bill and what the reality is and what we, the American people, have allowed to happen.
And I think it just gets worse. We talked about conversations I've had when I go on these road shows in Las Vegas. I talked to a number of people about this particular issue. Well, it happened again. And at dinner, one of our favorite grills we go to, talking to the waitress, who's a friend of our daughter. She told me that she's a single parent. She has to work 2 jobs, and she's paying $950 a month with a $60 copay. She's not getting any benefit from any of this, and it's gone up almost double year on year.
Yeah, and it's because she's earning probably just barely a little too much to afford the subsidies. And because everybody else is paying for the subsidies of the few, she's now in the many, and the many are paying a lot more.
And we knew this was going to happen. It was so blatantly obvious, but it sure wasn't sold that way, and it was a complete ripoff from the beginning.
It's a mess.
So I guess it's time that we write the next chapters in your book or a new book. What do you think?
Yeah, I think it is time. I think we can write the chapters, or we can start to do the additional podcasts and tell people how to fix the damn thing.
I think that's what we'll do. We will have that. And before we close out, though, for this, there's a few things we need to, I think, revisit. One is the HIV/AIDS epidemic. And I know you have a lot of background in this because you were providing a particular program. Please give our audience some background on this, the cost it had and has on our healthcare delivery, and the current status of this awful disease.
Well, while I was active in Washington, D.C., one of the top staffers on HIV and AIDS in Washington is a woman named Britt Weinstein. Yeah. And Britt was the chief of staff for Donna Christensen, who is was then the Democratic representative of the U.S. Virgin Islands. Now, the thing about Britt is she's a remarkable young lady and very, very bright and very smart. But she stood out in Washington not just because she knew just about everything there is to know about the issues related to the disease and the various legislations, but she was, unlike most people in Washington, she was very plain spoken. Mm-hmm. And in a meeting in 2008, she summed up for me the situation with HIV and AIDS this way. The problem for HIV and AIDS patients today, she told me in 2018, is that people are no longer afraid of it, and they don't feel guilty for people that have it. And that fact had a major impact on what legislation they were trying to do in 2007, 2008, 2009, and beyond. And in the end, not much happened then, and not much has happened since. Before Ted Kennedy died, one of his last efforts was he wanted to focus on rewriting the Ryan White Care Act. Now, Ryan White Care Act is the fundamental legislation that funds HIV and AIDS programs across the United States, medication programs, treatment programs. And everybody remembers Ryan White, the young kid that caught HIV and AIDS, and it really got America to focus on HIV and AIDS. But Kennedy wanted to kill the legislation because when the legislation was first written, as we showed in an earlier episode, HIV and AIDS patients had a life expectancy after diagnosis in their early 20s of about 8 years. So the legislation was written with this terminality in mind, and it was built around helping ease the burden on those patients so they could survive as long as possible and help them move on. It wasn't predicated on their dying, but the actuarial, the way you look at the numbers around this was based on an expected life expectancy. Yep. So Kennedy was unable to kill it. He couldn't get traction behind killing it and rewriting it with a new bill that was more appropriate because the many people in the HIV and AIDS community, the activists in the HIV and AIDS community, felt a bird in the hand was better than any two they could see in the bush. And there was already cost concerns about the rise in HIV and AIDS medications and treatment. There was a number of concerns about things that were happening at the state level with some of the state programs that were being funded. But most importantly, they just realized it was going to be hard to get any changes pushed through Congress. It was hard enough just to get the bill reauthorized. Mm-hmm. Well, Kennedy agreed to do that. The real problem with that was he couldn't get the law changed, but what he did do is he inserted a sunset clause in the legislation. You haven't heard anything about HIV and AIDS legislatively now since 2009, 2010. You haven't heard anything. It's gone the way of the white whale. And the second problem with it is not that we don't need legislation to help HIV and AIDS patients. They're not necessarily going to get all the care they need out of the Affordable Care Act. HIV and AIDS patients weren't eligible for insurance because of the chronic nature and the cost of the disease. And they weren't eligible to get it under Medicaid either. They could get supplemental coverage and supplemental programs through various states' programs like AIDS Drug Assistance Program in many states. But Obamacare took it away. No longer could insurance companies deny an HIV and AIDS patient insurance. Now they could get insurance. Ideally, it would have done something to reincorporate a review of the bill and rewrite, but we're still authorizing appropriations every year for the Ryan White Care Act, which in Ted Kennedy's view wasn't even appropriate in 2008. So it's still going on, and Obamacare's eliminated the original intention, but this is an area that you see often in government where these programs continue. So nothing's changed with HIV and AIDS. It's still dangerous. We talk of cures and other things. It's still something we should be afraid of, and it is still something where we should at least feel sympathy for the people that get this disease. And we really need to look as if the Affordable Care Act and insurance is going to provide good care for these patients.
Exactly. So technically, it's a continuing funding duplication. But HIV and AIDS is still a huge problem. Before I go to that, a couple things. I was living in Indianapolis during this whole Ryan White thing. And I believe he was from Kokomo, if I'm not mistaken. And he contracted it through a transfusion. Mm-hmm. That whole thing behind that story and what happened and the way that that family was treated and he was treated was just absolutely amazing. It's a short-sighted, narrow thinking. I remember it like yesterday. The other thing from your comments about Ted Kennedy, I didn't really ever really appreciate Ted Kennedy. There was a lot of things I didn't like about him. and I know you've met him and you worked with him, but there were some things that he got in this whole healthcare program. I think he understood a lot more than most people gave him credit for.
Yeah.
And you can still see that he's still having an effect from the grave.
The stimulus for the Affordable Care Act was work that Kennedy had done since Hillary Care. Yeah. And he had worked to try and come up with a plan through his Health, Education, Labor, and Pension Committee. And he had a bill called the Health Bill, and that was the first bill that I read. And he had worked long and hard to get bipartisan, bicameral support to come up with the things that were required to actually fundamentally fix healthcare. And if we won't go through them now, but if you go back and you look at those, you wouldn't disagree with anything. And he recognized a number of things that we've been talking about. He recognized that the cost of care for me as an individual was not the only goal solving that. You couldn't just solve mine. You had to solve it for everybody.
Right.
That America was not the same as an American, and that there was often conflict between them. And there's a series of things, but he had very strong support for the goals he had for the legislation he was working on. And when he died, none of that legislation made it into the Affordable Care Act. The last thing that was in there was the care part of the bill for the home care. And of course, they struck that and got rid of it.
Yeah. Again, AIDS and HIV are still a big problem, correct?
Yep. Well, and we don't have cures, we just have treatments. And converting this from a terminal disease 8 years ago to a chronic disease that we have today where people live over 30 years or more with the disease has had massive unplanned cost impact. And again, we're not saying people shouldn't get care. We're not saying that we shouldn't spend this money. We're just saying we need to recognize that we are going to have this problem over and over and over again with virtually everything in our lives as we get older. And this is a dynamic that we're going to have to build in when we start to think about how we're going to provide care for people. In 1982, we've got a chart up on the screen. The start of the epidemic, the life care cost for an HIV and AIDS patient over his life. And now remember, they were typically diagnosed at 22, 23 years old, and they were going to live about 8 years. So for the rest of their life, we were going to pick up a bill of about $1.1 million to help them stay alive till the day they passed. Yep. At the time of Kennedy's death in 2009, I think, when he died, may have been a little after that, it was $6.1 million for the same calculation. So in 2009, a patient that was diagnosed that year with HIV and AIDS, we were going to spend about $6.1 million to keep them alive until they died. In 2015, the last year we can get data, because for some mysterious reason now, they're not tracking this like they used to. It was $9.4 million per person with AIDS that in 2015 we were going to pay to keep them alive till the day they died. Now, again, we're not arguing they shouldn't be kept alive and we shouldn't spend the money, but we need to recognize this is a huge cost. And how big is that cost? Well, there's a lot more HIV and AIDS patients in 2015 than there was in 2008 as well. So if we're going to spend $969 billion to keep those people in 2015 diagnosed with HIV and AIDS alive, almost $1 trillion. That is a huge number. And if we keep going down this path, we're going to continue to layer one number on top of another on top of a number. We have to look at these numbers and try to find ways to mitigate, if we're going to pay that cost, how we're going to reduce it somewhere else. And we do, you and I know, and we're going to talk about it. We have a lot of ways to reduce the cost down so we can afford to pay for these things.
Yeah, I noticed in an article, another Modern Healthcare article that just published, the incidence of STDs is going up dramatically. And these are diseases we talked about in the past that the cures today with penicillin and so forth, they just don't work.
Right.
So, if you add that into this mix, and all of a sudden now you're going to have a bigger increase.
Yep.
So the next thing I'd like to address and get your input on is Medicare versus Medicaid. Now, ladies and gentlemen, this is a big difference here between Medicare and Medicaid. For those who don't understand, we're going to explain it to you. For those watching the video, there's a chart up there, and it's clear from the data that the cost of Social Security, Medicare, and Medicaid alone consumes almost all of the available federal revenue by 2062. And this is data from 10 years ago. I can't imagine what this looks like if we updated this chart today. Annual hospital admissions per thousand increased from 56.7 per thousand in the period of 1930 to 1949, up to 99.4 per thousand by 1958. That's right. After 50 plus years of experience, we now know the basic design of Medicare and Medicaid is fundamentally flawed. The relationship between government monopoly and purchasing power does not either yield the ability to control cost, manage program expansion, or keep consumers satisfied. In fact, it is now clear it produces just the opposite. Continually reducing reimbursements, increasing regulations, and expanding the required paperwork for provider participation will simultaneously continue to expand the eligibility of services available to the population is a magnificent perversion of the disciplines of an open market. And we talked about that a lot. I wonder what Wilbur Mills would think about that.
Well, before I tell you what I think Wilbur would think about that, when you were just bringing this up, it brought up another dichotomy that I think we need to bring up. We can't forget that right now the federal government has had a concerted attempt to redefine what value-based purchasing is. Yeah. You know, and they're trying to redefine what value-based purchasing is to convince people that if they get less but adequate service for a lowest possible price, somehow that is a value-based purchasing calculation. Right. And of course, nowhere the way we buy things in our purchasing psyche do we believe for a minute that value is based on the cheapest thing that's adequate. Right. Your definition of value and my definition of value are going to be different. And if we think we're going to push everybody into a bucket like that, we're going to have restricted care, we're going to have access to care reduced, and we're going to have certain kinds of care completely eliminated from our ability to buy it. So we need to be very cautious of these things. But yeah, you know, if you look back at Wilbur Mills, he knew this was the outcome that the extension of Social Security was going to have, and particularly if you included Medicare and Medicaid. As we discussed in prior episodes, Wilbur Mills thought Social Security was going to fail in his lifetime, and that was before we extended it to include Medicare and Medicaid. He argued repeatedly that the nation didn't have the ability to develop the cash flow from wages because wages weren't rising anywhere near fast enough to pay for the cost of health care as it was perceived to be targeted at that time. No matter how large a percentage of the tax dollars they were going to take, he was absolutely adamant that wages were not going to support it. And, you know, the problem was political expediency won the day, as we now know. Mills caved to the pressure, and he supported Johnson's Great Society. And if you remember the episode we did, 1.9, you know, Mills was still arguing with Johnson about there was no money in the budget to pay for this. And Johnson's argument was, oh, well, I haven't spent all my budget. I spent less. You know, I got $1.4 billion that I haven't spent. And, you know, that's going to be, well, that was okay, except there was going to be increasing costs every year. So it wasn't included in the way the government was going to move this thing forward. So I do think Wilbur Mills would have been surprised about one thing.
He was right.
Well, I think he would be surprised he was right, and I think he would be surprised that his fiscal fears arose in 1/3 of the time that he and his committee projected. We saw these costs hit literally way faster than he could have ever predicted they would.
Well, there's politics for you, right? The telephone call with Johnson, his analysis, and then caving to more votes. It's just, do you think that happens today? I wonder.
Now, you know, I don't think it happens today. We don't have politicians that would even think to behave like that, do we?
So let's go back. The biggest little secret of Medicaid is that the cost of this system, of this Medicaid thing, dwarfs that of Medicare. You know, Tom, can you please explain what this statement means to our audience?
Well, you know, Medicaid is interesting because when you look at the federal dollars in Medicaid spending, it doesn't really reflect the total amount of money spent in Medicaid, right? In Medicare, all the parts of Medicare are paid by the federal government. You got Part A, Part B, Part C, Part D. That all adds up. It's a nice little round number, and it works out all the time. But when you get to Medicaid, Medicaid is a partnership between states and the federal government. And many of the expenses of Medicaid never really show up in the federal calculation of it. For instance, the infrastructure for Medicaid is all paid for by the states. The people and all the things that administer it, they're not federal programs, they're state programs. And the federal government basically lists what they pay vendors under Medicaid, and they don't pay 100% of that. We did extend it under the Affordable Care Act to pay a bigger percentage of new enrollees. But the old enrollees, the ones that have been in, they didn't get changed on that. And so it's been an issue. But those are part of the problems that have been going on. The other thing about Medicare and Medicaid is politicians don't really want to talk a lot about the average Medicaid enrollee. They're not really the kind of person that people are going to feel sympathy for. That's not attacking them as people. It's just that they don't characteristically fit this nice little bucket the way Medicare patients do. We can feel sorry for grandma and grandpa and the fact that they need to have a hip replaced because they're going to be stuck in a wheelchair for a few years. The sympathy works there. Plus, the senior voting bloc is a very powerful voting bloc. And, they're very good. The senior voting bloc is very good for our professional political class because if the public reality ever came out and understood what the cost of these programs are each and every day to all of us, seniors and everybody else would basically be upset and the politicians would have hell to pay. Now, we're not going to make a big impact in this because while you guys see it and you're going to hear it, this isn't going to make the national news. It's not going to be the next thing out there because no one really wants to talk about it. But when the government mandated the expansion of Medicaid and Obamacare, something that, remember, the Supreme Court ruled against in their ruling. Everybody remembers one part of that ruling. They don't really remember this part. They basically said that they couldn't force the states to expand Medicaid. Some still went ahead and did it. And in fact, we have a couple of states getting ready to do it now. The problem with that is it isn't going to change the burden on the taxpayer.
No, it's going to go up.
It's going to go up. And when, the Supreme said no can do, and the state said, well, we'll do anyway, in the end, the cost is going to go up. The cost of the federal government's going to go up, and that's going to come to us in terms of federal taxes and fees for service and other things that we never see that drive the cost up. And the other side is going to be if the feds aren't paying for it and the states have expanded care, you can bet your state taxes are going to go up. We are going to see continual increase in that cost curve because we've created more and more programs that say everybody should get these things without defining specifically what those things should and shouldn't be. So this is going to keep going up. These chickens are coming home to roost. And with the further problem of insurance company subsidy payments going away, the so-called risk corridor is now gone, the opposite of the medical loss ratio calculation, which was to benefit the insurance companies. Now that they're unconstitutional, you can bet premiums are going to continue to go up and up and up, and the Medicaid burden for the states is going to become worse, and all that's going to come back and sit right in our pocketbook.
It sure will, and I don't. I think there is this misunderstanding. I think on the Medicaid side of the equation, because it's not your typical stereotype of a patient that you mentioned before, and it's sad because having provided in this particular market, there are a lot of people deserving of this. They deserve good care. We're going to talk about this in a few minutes. As you know, doctors don't have to take Medicaid or Medicare patients.
They don't, and many aren't. Many aren't taking them anymore, but that doesn't mean somehow that Medicaid patients aren't getting good coverage. In fact, in some cases, in some ways, Medicaid patients are getting better coverage than they're going to get under the public system today. And you can look at HIV and AIDS as an example of that.
Yeah, I would say that from my experience that they are getting, in most cases what I've witnessed, they can get good coverage and good care.
Yeah, they get the care they need.
Right.
They often don't get the care they want. And that's a real fundamental difference that we need to talk about in the future.
So let's talk about when doctors split with doctrine, one of the best lines in your book as far as I'm concerned. I experienced this because, having a bunch of doctors working in an organization, it was obvious to us that this was going to be happening sooner than we thought. So as we entered into the 1980s, doctors in high numbers began to leave the medical profession. We've heard about this in the news many times. The continual rise in the cost of malpractice insurance as a result of larger and more costly punitive damages awards against doctors quickly outpaced the ability of some of these practices to maintain, their ability to make money and maintain their practice.
Right.
As the country became more embroiled in a political debate over healthcare reform, once again, the AMA found itself at odds with its base of support, and more physicians started leaving the AMA. Right. Talked about that in the previous chapter. On March 15th, 2010, the New England Journal of Medicine reported that nearly 1/3 of practicing physicians might leave the practice of medicine. So, Tom, let's talk about this and when doctors split with doctrine.
Well, by the time the federal and the few state exchanges that actually did come online in October of 2013, some estimates show that over 1/2 of the physicians either were no longer practicing care or no longer accepting direct payment from insurers, meaning they no longer were contracting with insurers to provide services. And the reason was, if they were under a contract with an insurance company, there's clauses in there that require them to accept best and final payment and not be able to charge anything else to anybody. And they just objected to it because they knew that with the new law and the new reimbursements, all this was going to fall apart for them. So a lot of doctors said, I'll still treat you, but I'm not taking insurance. I'll give you the forms and you can send them in, but you're going to pay me. Mm-hmm. And if you have to wait, you wait.
Or you paid concierge.
Yeah. Or you sign up, I'm now concierge doc, or I'm just a retail practicing healthcare person. In fact, a lot of doctors set up retail care practices and they don't really practice 100% medicine in there. They do a lot of other things that they're making money on, and the little bit of medicine that comes up is really a feeder for their practice. So somebody goes in and they're getting some service that's being done in a med spa, and one of the nurses looks and says, oh, you may want to see the doctor. Then they go over to the practice and they go in for the kind of things the practice wants to see where they still make some money. Yep. So it's been the way this has changed. But doctors are not getting paid, and they're taking longer and longer, and they're being squeezed out of business, and they basically threw up their hands and said, you know what, it's on you. But remember, this isn't an accident. This wasn't something that happened accidentally. This is built into the part of the design of the Affordable Care Act. And remember, it was to break the system on all levels so the public and the healthcare industry would see that the government-run single-payer healthcare system was the only place they could go to get help. I better join the government system so I can make enough money to keep my practice open. Or I need to go over here because I can't get any doctors anymore. This was the idea. That's the real truth behind where we are and why we're here. If the industry and the people in America want this, more power to them. But I don't think they want this. I don't think doctors want to work for the federal government. I don't think I want the federal government, and most people want the government to deliver my care. I would even argue that Medicaid patients don't either, because some of the things that some of those Medicaid patients are getting today that are ancillary enhanced services because of the diseases they have, the economic reality of a single-payer system, they will go away. Care will end up being rationed, or some care that you want to get, you won't be able to get because it won't be there.
Exactly. So I want to expand on that for a minute if we can. As you know, before I came over here, I stopped at my medical group I go to because I needed to get some blood pressure stuff refilled. It'd been a year. Oh, no, we can't do that. You got to come in and do this, which was great because there was nobody in line. I went and got blood pressure check and physical, and she wrote the script, and she brought in a scribe, and we talked about this a lot. We talked about it before, They have to do this because all the time it takes for them to do all the charting.
Well, it's interesting because you're going to see the high priest of healthcare.
Right.
And like the high priests of ancient Egypt, they have to have a scribe.
They've got to have that scribe.
Yeah.
So just all this stuff, and we'll talk about that a little bit more, and we have some charts on this. If you're an individual practitioner in a group, you're getting squeezed, and your reimbursement's not going up. You got to hire people to help you chart because you're charting 20 minutes for every 2 or 3 minutes or 10 minutes you're spending with the patient.
Right.
If you don't get that charting correct, you don't get the highest reimbursement.
Right.
You're dealing with pre-authorizations. You're dealing with denials. You're arguing with the payers all day long, probably arguing with the hospitals. You're competing against the other guy down the street. And now you throw in the business associates agreements on the HIPAA side. You throw in MACRA, which has been becoming like a freight train, although I don't know exactly how that's going to pan out. And we have a chart on this. You start adding on the overhead that goes into being a private practitioner. I don't know how you do it.
Well, they don't. They're being driven out of business.
Well, let's go back to that point because exactly that. But the first step before the described working for the government is working for corporate practice of medicine.
Right.
So what we've seen, and we see it a lot, is the squeeze that certain IDNs are putting on certain markets and pressuring physicians to join their foundation here in California or other corporate practice of medicine states, or buying them and become an employee.
Right.
And they have to stick to the IDN or the healthcare system's practices. They don't stick to theirs anymore. They have to
Right.
follow their protocols,
Right.
which most physicians
Right.
really don't like.
Right.
But when you weigh out the cost, benefit, the quality of life, I don't have to deal with that stuff anymore. Many physicians are joining these foundations and these hospital systems.
But if you remember a few years ago, we were in Washington, D.C. at a conference, and we met a couple of physicians, one who comes to mind that was in West Virginia, who was a surgeon. And he was actually, I think, on the border between West Virginia and Virginia, and I won't mention his name, but if you remember, he came up and said he had been aggregated by one of the big companies, won't mention their name, and they had bought his practice, and he thought his payday had finally come in. So he sold his practice, and he got a job, and everything was going to be hunky-dory. And within 90 days, they got rid of him. And the reason was they didn't think they needed that many surgeons. He was 62 years old. He wasn't ready to retire yet. He's focused on doing breast reconstruction surgery and mastectomies, breast cancer surgery. Yeah. And now he was stuck having to start a practice all over again and trying to figure out how he could do it, because even though he still had privileges at the hospital, he couldn't do surgeries there because he could never get time in the OR. Right. And he couldn't get radiologists to read his mammograms because they were all working for the group that bought them, and they didn't want them to spend time. So then he had to go to a class and become a licensed radiologist or a licensed mammographer so he could read a mammogram.
Sure.
And this has happened to a lot of physicians across the U.S., and we've seen massive closures in rural markets because the aggregated physicians, these companies that went off and bought these things and bought all these practices, they learned very quickly that the average aggregated physician in these practices they acquired was costing them $170,000 a year. They weren't making money. They were losing $170,000 per physician they bought. So they had to do something to get rid of them, and they have. So you've got people that decided they weren't going to do it, people that have lost their jobs and have had to go back and start opening medicine again. Right. And now you've got this mess of a healthcare system where it's taking longer to get a visit. You're going in and you're getting all kinds of procedures and things done that they didn't do before because they need the billing, and we're getting worse results.
So think about this, expand the conversation around the topic of physicians going to the corporate practice of medicine. Then go back to the premise of saying, well, doctors, then if we have, quote, their single payer system, which will never exist, but let's just for grins say Nancy Pelosi gets her way and there's a single point of
single payer
administration. Yeah. And now all of a sudden the doctors all have to work for the government. Let me ask you, Tom, what happens to HCA? What happens to Kaiser? What happens to Dignity Health? What happens to Providence Health and Services? What happens to all of these people that are fighting for the same thing, and now all of a sudden we have everything owned by the government, and we fold them under the government? What do we do with all these people?
Well, it's interesting because that is a huge problem, and I think they believe that they'll still be the hub of care, and somehow or another they're going to negotiate these great contracts with the federal government. And in the middle of layering in that bureaucracy, they'll layer in more cost to deal with it. And some of them think that it's going to be easier because with the insurers out of the way, all of a sudden they're going to get paid more quicker. And that's not the case. No one is thinking. Everybody's trying to make the best of a bad situation, and no one's backing up from this mess of a non-system and saying, well, if we were to build this thing at the beginning, how would we build it and make it work?
Exactly. I think you have to, we'll get to that, the whole process. So let's talk again about where we are now. So comparatively, the last 40 years have dwarfed in sheer numbers the achievements of the previous 200. Mm-hmm. We've learned that in our history lesson. We have had more technological innovation, more medical innovation, more legislation and regulation, and more advancements in pharmacology during the last 4 decades. But we have not really gained a corresponding increase in lifespan. In fact, it's gone down. Quality of our health, or in the efficiency of the delivery of new cures. Tom, why do you think that is? It appears to me that we've hit the wall.
Well, Tim, you and I have spoken in the earlier episodes about myths, and these myths of care are the reason for this problem. We believe, as an example, we're getting healthier, but as a species, we're not getting healthier. We're getting sicker. We believe that we have cures for lots of diseases, meaning that they don't exist anymore and they no longer affect us. But this is also false. We have cures to the extent that the diseases no longer kill us. Right. But we still do get infected. And these organisms that were killing us before are evolving. They are part of natural selection. And we have many rapidly mutating diseases today, more than we had in the past, that become deadly in different ways. They might not require aerial transmission, but now they can be aerially transmitted. They're changing. They're becoming more dangerous, but we're not getting better. We're getting worse. We believe doctors are really good at what they do. Now, this isn't to say doctors are bad at what they do. That's not the point. Doctors are heroic people that go to great lengths to try and help us with disease. But the truth is they're good, but they're not as good as we think they are because they only get their diagnosis right about 50% of the time. There's no dispute to that number. When they do give a diagnosis right or not, only about 25% of the procedures that they use to treat us have a best practice scientific basis that back them up. So, 75% of the time, they just do whatever we've been doing for hundreds of years. We don't know.
One point, though, I'd like to point out, because we brought this up before, we're talking about diseases and chronic diseases. We have made great strides in trauma.
In mechanical intervention, we've done wonderful things.
Wonderful things, most of what we learned on the battlefield, unfortunately.
Right.
So I want to make everyone, don't think we're negative on doctors. The doctors do a fantastic job. No. But we're talking chronic diseases here.
Right. And when they do give us a procedure to treat us, they give us medication. And at best, only 60 to 65% of the population can even metabolize the drug that they're given. Yeah. And so, and the medications we're getting now are much more dangerous than they were 10 or 15 years ago. We picked all the low-hanging fruit. And 15 years ago, pharma and biotech realized there weren't any more low-hanging fruit. The things that they have now to treat disease are going to be more costly, and they are going to be more dangerous because they have more built-in side effects. The fewer side effective treatments are gone. We've used them up, and the organisms that we're using to treat them have evolved to say, hey, bring some more of that. That's like salt on my meat, so bring it on. So we believe, we've had this history of believing that if we're ill, more medicine is better. More medicine is good, is better for us. So we want more medicine. Give me more things to do. And the problem itself is healthcare itself is very dangerous and is getting a hell of a lot more dangerous since the ACA passed, frankly. Costs have skyrocketed. Medications have more side effects. Diagnosis and treatment have become less efficacious, and the average lifespan has declined by 2 years. And the risk of dying from healthcare has almost doubled from 263 deaths per 100,000 seeking care in 1999 to over 400 deaths per 100,000 people seeking care in 2013.
I was absolutely astonished by the data that you presented. It was almost 2 years ago. That's, I think, probably a little bit more different today, is that when people watch the show The Deadliest Catch, thought that was the most dangerous job thing you can do in the world.
Yeah, it is. It's still the most dangerous job you can have.
You can do,
Yeah.
but it's not even close to seeking health care.
No, because the risk for commercial fishermen is 200 out of 100,000 people die. 200 out of 100,000 versus 263 when we did that calculation first. In 2013, it's over 400 now.
So as Dr. Beckwith states in Money-Driven Medicine, hospitals are dangerous places.
And doctors' offices and pharmacists. And this is no slam on the doctor, no slam on pharmacists. It's just we are evolving to be more at risk because as we have removed ourselves from natural selection, meaning that something that would kill us so we don't reproduce, we now get medications or treatments to survive. We're now having children, and instead of selecting out the risk, we're selecting out the problem. So we're selecting and having children that are more likely to be obese, more likely to have diabetes, more likely to have these very rare diseases because we were allowing ourselves to take medications and develop procedures to allow us to be happy and healthy and have children. So I'm not arguing we shouldn't do this. I'm not making any statements that we shouldn't do it. I'm making just the clear recognition that this is a fact, and it's a fact that affects us, our future, the future of our generations, and it affects the cost of what this stuff is today.
And we're going to be talking about this in future episodes of probably Healthy Bites, because this goes back to this concept of a facilitator if you're not your own advocate.
Right.
And you really need to have somebody that's watching over you, because sometimes some of this stuff is getting away from you.
Right.
So let's wrap it up here and talk about our next topic, my favorite one, the ridiculous Patient Protection and Affordable Care Act, known as Obamacare. I call it the fleecing of America. You and I both read the legislation cover to cover, you more than once, and I know you have much more than I did. What a scam. You were on Capitol Hill at the time of this debate and saw firsthand what this legislation was and how the government, once again, can screw things up and screw us all while picking our pockets at the same time. Let's discuss one of the biggest deceptions in the history of healthcare in America and how even today we are being fleeced and deceived by this horrible and deceptive legislation. I want to focus on the day-to-day stories, costs, grief, some positive things, and what this means to the average American, because this nightmare is not yet over.
Well, the Affordable Care Act, like I said, was not really built to fix health care. It was built to get us to a single-payer system. That was the whole point of this legislation. And it is fundamentally shifted and destroyed what was at least somewhat of a working system before. Costs were still spiraling. We hadn't done much to solve it. And this didn't do anything to solve it. In fact, this has exacerbated that problem.
Right.
So it's, when I started the book, I started with Obama signing the legislation. And the opening of the book is setting the scene for when he comes in and signs the legislation. Yeah. And there was at least half of America that thought this was going to be a good thing. And the reality is, today, none of us are looking at this as a good thing. And the few that are, I would argue, are just so bound up in their partisanship they can't recognize where they are. And there's some on the other side that have hated it from day one and still hate it today. There are some things that worked in the Affordable Care Act. Number one is they eliminated pre-existing conditions. So now you could go get insurance. They didn't do it the way they should. They've put these people in high-risk pools, which have massively increased the cost, and they haven't gotten rid of the state borders. They've made smaller actuarial pools, not larger actuarial pools, all these kind of things. But it isn't like the total ideas, all the ideas in the Affordable Care Act didn't go anywhere and had no benefit. They did. The problem is they weren't integrated into providing a good solution.
No, they weren't. But the thing that disturbs me the most was the deception. I remember being in the provider side during this whole debate. I didn't know you at that point in time. It was a little later that I got to meet you. But I was reading and understanding and trying to get as much information as I could on this. And I would go to these conferences by these gurus of healthcare consultants, SG2 being one, Definitive Health being another. There's a few others out there. And I go to these conferences and I would sit there with all these healthcare executives, and these gurus would stand up there and tell us how great this was going to be. We're going to cover 30 million more patients. Your numbers were going to go up. This is going to be the greatest thing in the world because you were going to make more money. You're going to get more people coming into the system, and you would have a wonderful day. And I remember the CEO of the company I was working for actually saying that this is going to be a wonderful day. They took it hook, line, and sinker. And not only did they take it, so did the insurance carriers.
AARP took it.
AARP.
And the AMA took it.
They all took it. Now, I've got to give the administration and a few people a lot of credit for selling this deception. Because if you remember the professor, I think his name was Jonathan Gruber.
Jonathan Gruber, yeah.
And you take a look at what these other people were saying and the deception, and him standing up in front of his class. If you remember, I believe there were 2 videos that captured this, where he basically said, the American people were so stupid, we knew that we could confine this thing to the way we wanted it done, and they'd never understand it. And then Nancy Pelosi saying, we have to pass it so we know what's in it. And you look at that whole piece, you can keep your doctor, you can keep your plan. What a bunch of BS.
Oh, yeah. And there were a lot of people that were like me, that they weren't writing the legislation, they weren't in these meetings, working through all these things, but they were people that were reading the bill, that were communicating with people in Congress and passing back, the things that we saw and whether we thought it was good or not. And some people were hearing it and some weren't. And that's not necessarily Republican or Democrat. There were people on both sides that heard various pieces. There was some things that I advocated for that made it into the legislation. There was a thing about mandating coordination of care and benefits across all sources that got injected in the bill. By the time it got into the bill, it didn't mean anything because all the other pieces that were going to tie that together were taken out. So it's just at least half the people that I know that worked on this when the bill passed were pissed off.
Sure.
And that was why I wrote this book. I didn't write the book because I was pissed, but I did the research to figure out how we got to where we are, where we believe such stuff about this, that we could come up with an idea that the Affordable Care Act and everybody thought it was going to work. And I went on my own journey trying to figure it out. And I had, as I told you, about 26,000 overall pages of research that I looked through, about 11,000 pages of research that actually were called out and put into this book. And I was astounded. I knew some of the things that we were thinking as a population didn't work anymore. When I went back through the history and tied all this together, it was just clear as a bell that 90% of what we think about healthcare is not true.
It's not true.
And we've bought it hook, line, and sinker. And then if you believe it, you think, well, of course, the Affordable Care Act should work, right? Well, it should work. A government-paid system should work because the government can do anything.
Yeah.
But the reality of the history is the government has never been able to do anything to turn the cost down on anything in the entire history of America.
Exactly. And you can look outside the United States and see how well that's working. So, I do have to give them credit for one thing. They are masters at this whole marketing piece when they did this. They use the people's media. And even today, we go back to our experience in the episode on the 60s. I questioned everything. I questioned every single thing that came across. I researched it.
Mm-hmm.
And yet when I meet people today, and this is one of the reasons I think I got into history, into the research of these things, I don't believe any of it. And when the people that really, hey, if you believe the sound bites are going on in the media, and you see a lot of them now because of the elections today, the stuff coming out of these people's mouths is absolutely astounding to me. If you don't research it and understand it. Now, if you research it, you do the work, you understand it, you agree with them, okay, fine, I get it. But not going through the process of doing the wrench work to figure out what this means that we're not a consumer that's taking control of our own situation.
Well, why should we be a consumer? We've made this an entitlement. Isn't it the government's responsibility to make sure that I have all the care I want for the rest of my life, no matter what I do to myself in the process? and not the care I need now, not the care to stay alive and productive, but don't I get the care I want? I mean, if I have skin cancer, shouldn't I not have a scar? And if it's going to cost more not to have a scar, shouldn't you help me pay for it? I mean, really? Is that the idea we have here now?
And the thing about it is that the mantra right now, which people are still trying to figure out, is the value-based care. We're going to talk about that. Triple aim. We're talking about population health. Right. We're talking about ACOs. And in the latest article I sent you this morning, consumerism. So if we're talking about consumerism, what does that mean in this quagmire mess? And why are we talking about it? Because it doesn't exist.
But it does exist in what we're going to propose.
Exactly.
And in any solution we bring up, we have to recognize we have to deal with the care people need. And that's where we should build safety nets and where we should build cost-effective, efficient systems. But we need to limit to the care we need to stay alive and productive. And then we can have another market that's the care we want. We can have that. And in the care we want, we should be able to get it if we want to pay for it. We should have means and ability to pay for it. We should have the means to talk to a doctor and negotiate exactly what kind of care we want.
Exactly.
It doesn't need to be a separate doctor. It can be the same. We can build this so it makes sense. And the only thing we need in the middle of that is a single point of administration that coordinates the need care and the want care so we don't get cost shifting like we have today, where Obamacare subsidy payments and Medicare and Medicaid related patients are so cheap that the doctor can't afford to do it. And the doctor now has, if he's going to do it, has to charge everybody else more money, which never shows up to us in any of the accounting. These are the problems we need to solve for, and we can solve them very, very quickly and easily.
Yeah, we're going to talk about that a lot. And it just goes back to my point again about this whole mess. Lack of transparency. You have no idea what's going on. I equate it to this. Would you take your automobile to any place that fixes automobiles, give it to them and say, here, I think there's something wrong with this car. I'm not exactly sure. I want you to take it and diagnose it and do whatever you need to do. And if that doesn't work, then go do this. And once it's fixed or maybe working okay or something else, I'll come back and get it. And then I guess you'll just be sending me the bill.
Oh, sure. Yeah, I think that's a great idea.
Yeah, that's what we have.
It's a great idea. And I want all these changes to my car, okay? I don't just want to take it in and get it fixed.
Turbocharged.
Right? No. What I want to do is I want to start with a Volkswagen, okay? I want a Volkswagen. I got a Volkswagen, and you ran into it, and now I'm going to take it to somebody to fix it, so it's going to go to become the car I want. What I want is a Shelby.
Sure.
Okay, so you can buy a Shelby kit, and you can take everything on the Volkswagen out, and you can get a new motor and a Shelby and all that other stuff, and now I get a Shelby, and that should be covered under this, right?
As ridiculous as this sounds, this is exactly what's happening.
Yes.
And the whole transparency thing is a big, big problem.
Yeah.
And then other things we'll talk about. So, well, I think we got to the end of the history lesson, one way or the other. And again, from your book, The History and Evolution of Healthcare in America, available on Amazon.com. Go get it, read it. It's well worth your time. Now it's time to move on to the present day and the things that we need to address and fix this quagmire and solutions for a healthcare system that provides we, the people, what we need and what we want, what we just talked about. Two very separate things. So, Tom, what's your thoughts, going forward? How we, looking back a little bit, but more importantly, going forward in these next segments of our episodes?
Well, I think first, Tim, we want to thank everybody that's come along for the historical journey. We knew when we set out for this, it was going to be a big uplift, and we didn't expect everybody to sit through every episode at one sitting. So hopefully you're watching them in little pieces. We're surprised, frankly, I'm surprised at how many people do sit and watch them through. We've had good audience participation in watching the videos. We're getting good feedback from people. So we really do appreciate it, and make sure you keep telling your friends, we're going to fix this, but we're only going to fix it when we get a lot of people looking at this and talking about it. Going forward, I think, we've started to hint a little bit around ways that we can start to focus to fix this. We have a plan. There's a paper that's called, it's our white paper. Yeah. It's Health Reform 2.0, and it's a pragmatic solution to how we can solve for healthcare. And it effectively defines a good role for government. It defines good role for insurers and people that throughout the healthcare provider continuum. It defines a new role for somebody we call a facilitator to help people get the care they need and want and interface with doctors. One of the biggest complaints that you hear from people in the system is, well, you can't do it that way because the Gruber line. People are just too stupid. Well, okay, so if people are too stupid, which we don't agree with, by the way, but if you do have people that have a difficulty understanding their health care, then provide a role called a facilitator, something that doesn't exist anywhere in the general population of health. There are facilitators, they call them caseworkers in public health, who help people migrate their way through and figure these things out. But we need to define that role. And I think we can really build a system that's going to get us the care we need, cost effectively, efficiently, and appropriately. And it'll also give us a market where we can also get the care we want. We can lower the cost of care. The 60% or 60 cents of every dollar is wasted in healthcare. Again, a number that is not argued anywhere. And it comes in two categories. It comes in 40-cent waste in duplicated services and 20 cents in fraud and abuse. We believe that if we put together a system that coordinates all the care and benefits across all available sources from both marketplace, we can cut a huge percentage out. So let's not use the 60 cents. Let's say we can do 30 cents, half of it. 30 cents out of $3.8 trillion is a huge amount of money. And it's going to free up physicians from doing defensive medicine and things that bring us no benefit. And it's going to bring us the physicians we need to care for people and lower wait times because they're not doing things that are inappropriate or duplicative. And the other thing it does is it puts all their costs, all their pricing, all their performance up where the buyer can see it.
Exactly.
And then you can make educated decisions or have your facilitator help you make educated decisions about the people you're getting care from.
And we'll be speaking at a conference, I think, Friday on this. We're anxious for that. So I think that also going forward, we're going to do more Healthy Bites on specific topics. One I want to do is on joint replacement. A lot of things you need to know about that.
Yep.
Breast imaging, breast cancer, the transparency issue, some of the myths about what you told you.
We want to make sure we say we're going to do a lot on breast cancer and imaging related to cancer. We don't want people to think we're going to become a porn channel.
Exactly. I speak in diagnostic imaging.
Exactly.
A lot of experience there, and there's some other things too that I think we can bring out that give you some insight into some of maybe the things you're facing today and some of your healthcare issues. So thank you very much for joining. It's been a pleasure and looking forward to the next episode.
Thank you, guys. See you again. Bye-bye. You've been listening to Health Reform 2.0 with your hosts, Tom Locher and Tim Henning. We hope you found the topics interesting, that we answered a few questions, that you laughed a bit, and were entertained. Please feel free to invite your friends to join the discussion, and remember, hit that like button and don't forget to subscribe. Send us your questions to info@hr-20.com. We hope to see you again next time.